Welcome, one and all. Class number 6. At the end of tonight, you will be 20% of the way through this class, almost a quarter. Tonight, we're going to go over Chapter 11, Airways. Thoughts for the day. Nobody knows you better than yourself. You know what your strengths and your weaknesses are. So whatever someone else says about you doesn't really matter because they don't know you as well as you do. Embrace and improve your strengths. Identify your weaknesses and practice, educate, and train yourself to improve your weaknesses and make them strengths. Any questions? By the end of tonight, you should know the major structures of the respiratory system, basic physiology of breathing, adequate breathing, inadequate breathing. How do we deal with someone that's not breathing, which is apnea? Apnea is a vocabulary word for not breathing. And we're going to describe the process for assessing and managing inadequate respiration. They are breathing, but not breathing adequately. Any questions? We're going to go over how to open and maintain an airway. You've already been taught how to use an OPA and an MPA, but we're going to teach you how to use an iGel. Being airway is outdated. iGel is a form of LMA, which is laryngeal mask airway. We're going to go over the importance of suctioning, and we're also going to teach you about CPAP, which is an amazing tool that you now have in your tool chest that I wish we'd have had 30 years ago. And CPAP is continuous positive airway pressure. It's a very, very, very impressive life-saving tool. All right, here's my drawing of an airway that I did myself. You guys should be familiar with the airway structures. Any questions? Now here's something we hope you'll really like. Very important. Lots of test questions. Let's cut him off.
Why was chapter 11 due today if it wasn't even gone through?
What you talking about, Willis?
It says on our syllabus.
That is
10
such
and
a
11
good question.
were due today, but we haven't even gone over 11. That's why I struggled so bad with 11.
Because we're supposed to have it done before we do class, and then we go over it in class. Just have it read, and your chapter's done before we go to class. Then we review it in class because you've already read all those chapters. That's what.
Making sure. Yeah,
We're just a little bit. You guys are spoiled because we're a little bit ahead on presentations. We're supposed to start chapter 9 tonight. If you look at the syllabus. You don't feel spoiled?
No, because the test is still due today. We're only supposed to be on chapter 9. Then I
Right,
feel
but you're
like
supposed to
we're
read
on
the chapters
No.
and take the practice test. So if you've read the chapters, you should be able to do the practice test. And then you come in here and you watch the monkey get up here and go over all the stuff that you've already read. That's how the class works.
Well, you throw us off getting us so far.
Yeah, well, I'm just an overachiever. You want that if your life's in danger. You want an overachiever. Believe me, we're going to get cold once these chapters start getting in depth and I start really talking, and it's going to take longer and then it'll catch itself up. This is only the first time I taught this class, so I'm pretty sure that's what it'll work out. All right, so we're going to review the breathing process. I can't do this without my stick.
Did they move or did you move?
No, I moved it. Somebody keeps putting it back together. I've had this stick for like 20 years. As you can tell, they keep taping it back together for me. Otherwise, I can't function without it. Kind of like Linus and his blanket. So it's got to be this one. They gave me a metal one. It doesn't. It's gotta be this one. It's a magic stick. I like Dumbo and Magic Feather. Can't teach you about the magic stick. So breathing process. We've already been over this. We're going to go over it again. You flatten your diaphragm, expand your intercostal muscles. That creates a large cavity inside your thorax, which creates negative pressure. So atmospheric pressure and air rushes in. Then as you relax your diaphragm and your intercostal muscles, that creates greater than atmospheric pressure and the air rushes out. When the air rushes in, it exchanges the gases, oxygen for carbon dioxide at the alveolar level, and then it blows it right back out. Any questions? So critically important that you understand how breathing works. It is essential that you do this at least 12 times a minute, all 60 minutes in an hour, and all 24 hours in a day to stay alive. Questions? And there's the exhalation process. Flatten when you relax your diaphragm and your intercostal muscles. All right. Next slide. Oxygen is critical for the cells. Your cells do not survive if they do not have oxygen and glucose. Try to bring it. All right. 0 to 1 minutes without oxygen, your heart cells will get irritable. After 4 minutes, your brain starts to die. After 6 to 10 minutes, your brain likely not going to survive. Maintaining an airway and adequate ventilation is critically important to patient survival. Any questions? All right. The gas exchange. Again, 21% oxygen in the air. You inhale that. Goes across the alveolar level, then you exhale. There's still about 16% when you exhale out, but it's also got a lot more carbon dioxide in it. Any questions? Hypoxia is going to be on so many test questions. It is a test question or a test. It is a vocabulary word you must know. When there's not enough oxygen for the cells, metabolic process. Cells cannot work. When the cells work, that's metabolic process. If you don't have oxygens, then the metabolism doesn't work, and the cells die. Then you die. Any questions? How do you become hypoxic? We're not breathing adequately. We're not breathing at. Any questions? All right. So how, when you're doing your assessment, do you know someone is possibly hypoxic? They have nervousness, irritability, fear. Their heart rate shoots up over 100. You can see accessory muscles in their neck, their clavicles. They're tripoding. They're leaning forward. They can't speak a whole sentence without taking a breath. They're obviously struggling to breathe. Questions? All right. So what can cause that? Myocardial infarction, that's a big word. Let's break it down. Myocardial is? Infarction means death of tissue. So what does that mean? Heart attack, death of tissue. What a heart attack is, myocardial infarction. Abbreviated MI. Or AMI for acute myocardial infarction, meaning that it suddenly came on. Next thing to cause it is pulmonary edema. That's when your lungs start filling fluid. They're backing up from the pulmonary artery. No, not pulmonary. The pulmonary vein. Or from disease or other things. Your fluid starts filling up your lungs. You can't do the gas exchange at the alveolar level. Well, you can't breathe underwater too. One of those common ones is acute narcotic overdose. Narcotics are central nervous system depressants. Your breathing is run by your central nervous system. So when you depress it with a drug, such as a narcotic, you stop breathing adequately or stop breathing together. Smoke inhalation is another one. If you get have a stroke, the part of your brain that maintains your airway and breathing dies, you will become hypoxic. Chest trauma, shock, lung disease, asthma, which is a lung disease, and of course, children born before 36 weeks gestation, whose lungs have not developed yet. Any questions? All right, we'll move on to the next slide then. So, again, adequate breathing. If your patient is breathing adequately, they'll look like everyone in this room. Any questions? Inadequate breathing, when all the things we talked about before. I clipped this video. is actually the longest streak we've gone without YouTube removing it for copyright violation. Um, this is a great example of an officer that's doing his job and doing what he's trained to do, which is try to keep someone still when they've had a major traumatic incident. But in this case, this guy can't clear his airway, and you'll hear the sounds of his airway, him trying to clear it. And finally, he doesn't do what the cop says. He actually gets his head up and spits all the blood and stuff out of his airway and clears his own airway. But for a while there, he's not adequately breathing. Fortunately, he woke up enough that he was able to clear his own airway because the officer kept pushing him down and do his own blood. You know, hold still, buddy, hold still. Help's on the way. This is a good video. Tony, clear your own airway. Pretty good mechanism injury there, eh? Here's a 97% blocked airway from a tumor. You can actually see the tumor in the throat there. At emergency surgery was blocking 97% of the airway. All right. There's normal respirations for adults, children, and infants. Those were abnormal sounds that you heard there. A person breathing adequately does not sound like that. Any questions? Any questions on normal respirations for adults, children, and infants? The Marlboro Man. Most of you probably don't know who that is. He sell a lot of cigarettes. Anyway, this is poster child of chronic obstructive pulmonary disease, which you get a lot of test questions on. It's also abbreviated COPD. It's a catch-all for all chronic respiratory diseases. And chronic means it never going to get better and it's always going to be there. But it's a catch-all for all of them. The four biggest ones are emphysema, chronic bronchitis, chronic asthmaticus, black lung. One we see mostly up here in Northern California is emphysema. If you worked in coal mining regions like West Virginia, Alabama, Georgia, in those areas, you'd see a lot more black lung. That's what comes from coal mining. Any questions? So again, this guy, when you see someone looks like this, you know, look how well developed his intercostal and his accessory muscles are, and the barrel-shaped chest. That's because he's constantly, 24 hours a day, struggling to breathe. Any questions? Oh, and those are all the signs. By the way, there will be test questions. Any questions? All right, so agonal breathing, that'll also be a vocabulary word you need to know. Agonal breathing is basically, agonal means dying. And it's a breath that's completely inadequate. So if you take a breath every 10 seconds, like 6 breaths a minute or 4 breaths a minute, so it goes kind of like this. And nothing for 10 seconds. That's what agonal breathing is like. You start ventilating those people immediately, get an airway in. Okay, and Stokes breathing is associated with brain trauma. That's when it gets deep and rapid, and then shallow and rapid. Deep and rapid, and shallow and rapid. It's kind of a graph showing you how it works. And you see that in an unresponsive patient. It's really bad. Any questions? It's a sign of major brain trauma. Also known as ataxic respiration. Yeah, Kussmaul respirations are deep, rapid, labored respirations. Those are common in patients that are having acidosis. The most common one you'll see it with is what's called diabetic ketoacidosis, which we'll go over after midterm when we do endocrinological emergencies, mostly diabetes. And it can also happen with types of heart failure. and sometimes trauma. Any questions? So we always listen to lung sounds on every patient. 100% of the time. It's critical failing skills if you don't. And as part of our ABCs, we assess their airway, their breathing, and are they breathing adequately? If they are not breathing adequately, we need to ventilate them immediately. Did you have a question or are you stretching? No. Okay. Any questions? So make sure they're not breathing too shallow or too fast or too slow. Pulse oximetry is a very good tool. Never treat the number is one part of the assessment. You look at all the positive findings combined, form your primary impression. You never form an impression based off one number of a vital sign or an SpO2 machine. Any questions? And pulse oximeters are chronically wrong. Any questions? Like ghosts. So entitled CO2, in California, you won't be able to use it. You can use color matrix. You don't get to use waveform. This is for waveform. I don't believe there are any test questions on it. The range, in case there is 35 to 45 is what you're shooting for with ET CO2 capnography. If it's below 35, it means they've been over-ventilated, ventilated too much. If it's over 45, they're not breathing. They're not ventilated. It's the level of carbon dioxide being exhaled. So if there's too much carbon dioxide, you're not ventilating enough. There's not enough carbon dioxide coming out. You're over-ventilated. Any questions? Any questions? In some states, EMTs are allowed to use it. You probably should know it. So it also gives you your respirations. Great for EMTs that aren't competent enough to count respirations. You can put on capnography, it'll give you the respiratory rate. It measures the exhalation. Any questions? So this is a good example. So this person's taking deep, heavy breaths. It's not showing their, never mind, it's not that good. Thought it would show the actual reading. It doesn't, just shows the waveforms. So basically the first one there is adequate. The second one there is inadequate. They're rapid and shallow. They're not blowing off enough carbon dioxide. And the third one is basically not breathing at all. That's happening. So if you don't suspect spinal trauma, and you need to open someone's airway, the preferred method is the head tilt, chin lift. Any questions? Putting the patient into the sniffing the morning air position. If you suspect spinal injury, you should not use the head tilt chin lift. You should use the jaw thrust maneuver. You take up the temporomandibular joint. I don't recommend doing it to yourself. I don't recommend doing it to yourself. It's not fun. And you move the mandible forward so it takes the tongue off the airway. Any questions? And it hurts. It's also a good point to find out if someone's truly unresponsive. If they're not truly unresponsive, they probably are not going to really want you to do that. That's probably the fakest picture of all time. No one that clean. There's never been a gunshot wound in the history of the world that is that clean. Come on.
Sound mad about
There's a knife
this.
in the corner right there.
Okay, so it's a knife wound. They're still not that clean.
You sounded so upset about it.
It's so ridiculous. I've never had a clean trauma victim. I just come out of the shower and I got stabbed. Yeah, come on. That only happens in the movie Psycho. All right. That was chocolate syrup, not even real blood. Oropharyngeal airways, you guys are pretty well versed with those. Any questions? No questions. I didn't think you did. Same with nasal pharyngeal airways. Any questions on how to put an OPA in? Any questions on how to put an MPA in? I bet he didn't really take that MPA. They cut the end off of the picture. That's a good picture showing you how the MPA keeps the tongue out of the way and secures the airway. Any questions? Good picture. Any questions about suctioning? You guys have been taught pretty well about that. Never suction farther than you can see. Make sure your suction's working before you try to suction. All right. Make sure you can turn the unit on. That's a great tip. Never suction further than you see. There will be test questions about ventilation and suctioning. Suction 15 seconds for every 2 minutes of ventilation. That will be a test question. 2 minutes of ventilation, every 15 seconds of suction. Do you have any questions?
Can you take a guess on how many times you said that today?
The thing's going to tell me how many times. 12? 30?
Yeah.
Any questions or are you counting any questions?
Yeah.
Oh my God.
I guess 32.
Okay, I'm switching it to y'all good.
No, that was so much worse.
Any questions on the suctioning technique? Sort of 33 now?
Not even 7 yet.
I know. We're not even halfway there. All right, that's recovery position. So we put people in recovery position if we do not suspect spinal trauma. We want to protect our airway. If they decide to vomit, we want gravity to be in our position of the best gravity to keep it away from the airway. Make sense? Any questions? All right. O2. All patients in cardiac arrest should get oxygen. That's a really good tip. Never withhold any oxygen for anyone that may benefit from it. So one of the things that you might have a crotchety old nurses tell you about is someone that's called a retainer for COPD, chronic obstructive pulmonary disease. If you leave people with chronic obstructive pulmonary disease on high flow 2 for too long a period of time, for like hours, they don't work off the regular carbon dioxide drive we talked about. They work off the backup system, which is the hypoxic drive. So if you completely erase their hypoxia after a certain period of time, they'll just stop breathing. However, in an emergency EMS situation, when you're bringing someone in severe respiratory distress, never withhold oxygen because they have COPD. That's the hospital will figure that out and they'll titrate it appropriately when they get there. But you might get someone that doesn't understand EMS and doesn't truly understand what they're doing, but they're in the position anyway, which is common since COVID. We'll say to you, you can't have them on oxygen, they're a retainer. And it's just kind of go, that's okay, we can educate you later. Don't say that. Just smile, acknowledge them, and say, okay. Then let them go about their day. Any questions? All right, oxygen cylinders. Before I go over those, I know we already went over them, but we're going to go over them again. It's a compressed gas cylinder. They're extremely dangerous. You want to keep open flame sources away from it. It's not flammable, but it is the best oxidizer on Earth. That's why they call it oxygen. What does that mean that it's the best oxidizer on Earth? Well, oxygen is not flammable and oxidizers aren't flammable, but they support combustion and they support complete combustion. So we used to have a really cool class here at COS for the fire academy. It's called fire chemistry. It's one of the best classes I ever took. And the instructor one time came in and he had a beaker with a cardboard board on top of it. He said, inside this beaker, we have pure oxygen. I want to show you what pure oxygen does. So he lit a ton compressor on fire and shook it out so they had a couple embers. And he dropped it inside the beaker full of pure oxygen and it vaporized, disappeared. Magic. Because what happened was it gave complete combustion of the flammable product. No smoke, nothing. Completely annihilated. It's amazing. That's how well oxygen supports combustion. So if you already have a fire or someone smoking a cigarette, you come in with oxygen, you can increase the amount of combustion and fire by 100 times just by adding pure oxygen to it. Does that make sense? You never want to set an oxygen bottle straight up and walk away from it. Someone always needs to be holding it or it needs to be laid on its side. If they fall over and it breaks the neck, it becomes an amazing torpedo that can be fatal if it hits another human being. I have videos somewhere YouTube takes away because they don't, it's against their community standards, where they've intentionally broken the necks off of large oxygen tanks like the ones in the ambulances. And it goes through like 4 to 5 different walls without stopping. It's that impressive. So never, ever, ever leave an oxygen standing up. That's a critical fail in skills. Any questions? Flow meters. So if you're using a pressurized wall mount flow meter, it has to be straight up and down as it runs off gravity, whereas in a burden gauge flow meter with the needle, you put in any position. Any questions? Any questions on putting on a flow meter onto an oxygen cylinder? Yes, onto an oxygen cylinder. No questions, huh? Any questions about how to use a flow meter? So if you want to increase the oxygen, you turn the dial on the flow meter. There'll be a test on that at the end of the day. Questions? Another thing about oxygen cylinders, keep any hydrocarbon products away from them. It can cause hydrocarbons to spontaneously combust. What are hydrocarbons? Methane, butane, propane, octane, so no diesel and gasoline products. No Vaseline. Vaseline is the same carbon and hydrogen compound as gasoline and propane. It's just more of it and it's now in a solid form. Light a jar of Vaseline on fire sometime, you'll see exactly what I'm talking about. I did not tell you to do that. And then open some oxygen up. Any questions? We're not teaching arson in here. Non-rebreather mask, you should be holding down tab like we taught you, filling the bag, then putting it on the patient. If you put it on the patient perfectly, under the perfect circumstances, you should be able to count the respirations in the reservoir bag. Every time they inhale, it should hit that bag. If you do it perfectly. Nasal cannula goes in the nostrils, goes around the ears, and tucks up under the chin. It does not go behind the head and tighten like a hangman's noose. It's not what we do here. Any questions? That is what a perfect application of a non-rebreather mask looks like. Granted, she doesn't look ill or in need of one, and I'm sure it's modeled, but they did it pretty good. Any questions? That's what a nasal cannula should look like if it's done correctly. Any questions? All right, ventilations with a BVM. Preferably if you have the manpower, and you haven't put an iGel in, you'd be using 2 people to do a BVM. One person should be holding the seal with 2 hands while the other person ventilates. Now, they're gonna be test question. It's a tricky one. We're gonna give you some cliff notes here. There will be a test question. The National Registry loves to throw out there different formats. I can't tell you exactly what it'll say. They're going to ask you a question, something similar to like, what gives the greatest volume of air for artificial ventilation? And they're going to say bag valve mask, Elder valve, mouth to mask. So your highest flow of oxygen can be given through bag valve masks. So they're not asking that. They're asking what is the greatest volume. So bag valve mask is about 800 millimeters of air if you use it perfectly and ring the bag. Your lungs, in an average adult, is 1,200 to 1,500 cc's of air. So the correct answer or the best answer is going to be mouth to mask, although we never known that. It is the largest volume. So I want to make sure that you understand volume versus flow. Any questions? When you see that question, now because of me, you know how to answer.
Okay, thank you, Brian.
Give myself a good pat on the back for that one.
I would love
Any questions about ventilation rates and using BVM? By the way, BVM is not a German car company. It stands for bag valve. Don't use mouth to mask. If you do, make sure you have a one-way valve. Kind of a cool setup there. It's got the oxygen coming in. What they're doing is doing blow-by oxygen, so when he blows into the mask, it forces in even more oxygen, so it's above 21% air. It's kind of cool.
So one-way valve, like about that big, and it's like.
It's got a disc in it so that the AIDS, when he exhales, all the droplets of hepatitis and AIDS and tuberculosis, you don't inhale it back in with your mouth on it. That's the idea.
Okay, I was given one in class one time. I didn't know what it was, so.
Yeah. Still don't really recommend it. It's the last option. If at all possible, use a BVM.
Yeah.
Just for safety purposes. You want to learn a dinosaur trick if you don't have the oxygen outlet there, you put a nasal cannula on whoever's doing the mouth to mask. You inhale through your nose at 6 liters, then you blow into the thing. That bumps you up like 40% oxygen over 21%. Actually 16%. Because when you exhale, you're only exhaling 16%. So that bumps your oxygen exhale rate up. You're inhaling oxygen through your own nose. It's how back in the olden days, before we had BVMs and stuff readily available, that's how we did baby CPR. We'd always throw a nasal cannula on the guy doing the baby and 1, 2, 3, 1, 2, 3. We'd always inhale through our nose. I don't recommend doing any of that anymore. Just kind of a cool history lesson. Any questions? Or in case we have an apocalyptic disaster and go backwards like 100 years, then you'll know how to do that. All right, I think we've beaten this horse to death pretty well. Any questions on the BVM? That looks good right there. Good. But a lot of times you're not going to have the manpower, so you're going to have to do it like that at one person. So flow restricted oxygen powered devices, these things are freaking awesome. You'll probably never see one again in California because they were misused. And in California, we don't blame, we don't take or get rid of incompetent EMTs and employees. We get rid of the tools because it's always the tools fault, not the person's fault. So, and what they're doing is they're over ventilating people. So what it does is you press that button and it gives a 50 PSI jolt of a pure oxygen to the patient. Or if you can get a perfect seal on it and it senses negative pressure, it'll automatically do it. So like if they're in respiratory failure, it'll actually ventilate them like a ventilator. Coolest thing ever. And you can hold it like when we're doing CPR, you can hold it with 2 hands and you can hit the button with your chin. So you got the best of both worlds, but unfortunately, people did horrible things with it, and you just don't see them anymore. But it's a great tool. when used appropriately in the right hands. Any questions? How do you know if you're adequately ventilating someone? You can see chest rise and fall. You can see changes in vital signs and SpO2. Versus inadequate ventilation, you're not going to see any of those things. And they're going to continue to get worse or die. Any questions? All right, you can mark it down. Oh, good thing I'm watching you. All right. The Selleck maneuver. This was invented by Magnum PI. Take cartilage, blow the out of the apple, like a diamond-shaped cartilage with a little soft diamond-shaped membrane inside. And if you push in on that, it collapses the esophagus. So when you ventilate the patient, all the oxygen doesn't go down into the stomach; it goes actually to the lungs. As air flows the path of least resistance, and the esophagus is about 2 to 3 times bigger than the actual airway is. So you do get a lot of air that goes into the stomach when you're doing artificial ventilation, which is a bad thing, especially if you're doing CPR, because you're pressing up and down like a piston on the diaphragm, and it's turning up the gastric contents, and then you're aerating the gastric contents. Pretty soon the patient goes and blows vomit all over the entire code team. Any questions? You don't want that to happen. That's what we're talking about, gastric distension. That's why it'd be really smart to put an advanced airway in as soon as possible. And we're going to show you how to do that tonight. Any questions? All right, this is a big one. Stomas and tracheostomy tubes. I cannot tell you how many times I've walked in to see someone in agony, difficulty breathing, with a non-rebreather mask on their face and they're breathing out of a stoma. If you have a stoma, you have to put the oxygen on the stoma. That's where they're breathing from. They don't breathe out of their mouth. Any questions? And if you have the ventilator with a BVM, you take an infant mask, you put the infant mask over it, hold it directly over it. You ventilate. Any questions?
You only hold it on it, you don't press it down on it.
Yeah, you gotta make a seal. Oh, it won't work. Yeah.
It would be the same as.
Right, except you're gonna use an
It'd be
adult
the same
bag
compression.
with an infant mask.
Yeah, it would be the same compression, so yeah.
Same compression for, oh, yeah, same ratio as an adult. You're just ventilating the hole instead of ventilating your nose. Any questions? All right, foreign body obstruction. So the biggest airway obstruction, the most common, is the patient's own tongue, especially in little tykes, children. When they go unresponsive, they got that big head, anterior soft little airways. It shuts off their airway with their big old tongue. Same thing with adults. So with adults land in the wrong position when they go unresponsive, their tongue can shut off their airway. Second thing is blood clots, bone fragments, and pieces of tongue and lip and cheek from major trauma. And then lower than that is swelling caused by allergic reactions, then just other foreign objects like food, etc. choking. Any questions on how to plug someone's airway? All right. So you can have partial airway obstruction or have a complete. If it's complete, they're probably going to give you the universal choking sign. It's just what people naturally do, no matter what language. That means that they can't breathe. So how you determine is, can they speak or cough? If they cannot speak and they only have little whiffs of air, that's considered a complete airway obstruction. If they're able to speak still, they're just in severe distress, that's a partial obstruction. Sorry, I didn't get to bring my caffeine with me today. Partial obstruction, though, we just let them leave them alone, try to get them start moving towards the hospital, let them try to expel it. We don't try to interfere. If it's complete obstruction, what we try to use pneumatic force to clear the airway. Pneumatic force. How do you use pneumatic force? What you want to do is, everybody knows how a piston, right? Pneumatic piston. Because you want to create a pneumatic piston. So you've got a complete airway obstruction here. You want to get under the diaphragm, and you want to compress the diaphragm in and up as fast as possible in one fast fluid motion. So it creates massive air pressure and projects it out. Invented by Dr. Heim. That is Heim, not Heim. Heim. Huh? The ghost did not. Ghosts don't like me. Anyway, never really popular to the ghost crowd. Never get invited to parties. Following so willingly. Anyway, now that's it, they're conscious. If they go unconscious, believe it or not, so we used to teach, you lay them down and you do abdominal thrusts. Found out that's not effective. But actual hard, fast chest compressions, just like CPR, is more effective because what it does is it's complete blood and you're pressing down fast. It's compressing the entire chest. It's creating the air pressure to pop out. So do not use abdominal thrusts that are unresponsive. We use chest compressions now. Hard, fast, deep compressions with full recoil until it pops out. Any questions? All right. We already went over that. Any questions? From the Heimlich maneuver. May have been German, but not the same German that invented the BVM car. Right. So I personally recommend anytime you have someone that is unresponsive and not breathing adequately, you need BVM, is to get an oropharyngeal airway in to make sure they don't have a gag reflex. If they don't have a gag reflex, as soon as possible, put in a laryngeal mask airway. So, or an IGL. IGL is the best laryngeal mask airway on the market. It is beyond simple, and I'm going to show you how to use one. Maybe.
The iGel is a novel and innovative suprachoroidal airway. Gel-like and advanced packaging.
Any questions? All right, so another tool you guys get to use besides IGL is CPAP. So CPAP is for people that are breathing adequately, that are in severe respiratory distress, usually congestive heart failure, or there's fluid building up in their lungs, their blood pressure's through. What CPAP does is CPAP increases the atmospheric pressure inside your chest, or the pressure inside your chest. So what it does is it's a sealed mask on high pressure with a relief valve that only lets a certain amount of air back out. So it keeps the lungs fully inflated. So like we talked about earlier, most of us have, an average adult should have about 1,500 cc's of air available for their lungs. We only use on average like 400 to 500 of that. So a lot of the alveoli, the tissues, the distal spots never even get used, especially if we don't exercise. We become couch potatoes. And it's called atelectasis, where they're stuck there, they're all stuck together. And what the CPAP does is it opens it all up, and then it can triple or quadruple the amount of gas exchange, because now it's using the alveoli that we never use. Any questions? And when you put this on, it's amazing. They go from not being able to breathe to speaking one word sentences to, wow, I feel much better in speaking whole sentences like that.
Kind of work the same with as people that sleep with it on. The same.
Yeah, but that's like 1 to 2 pounds pressure. That's just to keep them from snoring and from keeping their tongue from closing off their airway while they sleep. So it gives them better sleep. This will actually put them in a completely different state for a severe respiratory distress. This one we start at 5. So the ones for sleep are 1 to 2 centimeters of water pressure. These we start at 5. We can go all the way up to 15. So it's way higher levels of pressure. Here's a demonstration video on it. Good, man. We shut off their volume. That's what it looks like. Any questions? Wow, that was timed perfect. Good. All right, oh, shut up. All right. So this is an excellent video. Guy who made this is top notch. So this is actual deer lung, and that they're using PEEP instead of CPAP, but it's the same process and the same thing. So it shows you what a lung looks like under normal respiration. Then as you increase CPAP, how much more lung expansion and how it stays expanded. Pay attention to this guy. He knows what he's talking about. Any questions? Make sense how CPAP works? Actually see the lungs? Yes. So do real lungs. Because deer lungs. They're not in the deer anymore.
Was that you doing the video?
No.
No.
Can we look
Did he
at
say,
the
did
profile?
he say if you had any questions? No, he didn't, so it can't be me.
Oh,
What's that?
this. You're not subscribed to your own channel, bro?
Yeah, because this is a different profile from that channel. This is before I created this profile for COS. It's going way back when. The indications for CPAP. You can't put on someone under 8 years old. Their airways aren't strong enough to handle it. Got to be in severe respiratory distress or congestive heart failure or pulmonary edema. They cannot be in respiratory failure. And if they're severely altered, that's the beginning signs of respiratory failure, you cannot put it on them. Their respiratory drive has to drive it. It's not like a BVM. If they're going into respiratory failure or severe ultra low conscious, you have to bag them. Use a BVM, do not use CPAP. Any questions? You also have to have a systolic blood pressure of below 90. Below 90, pressure inside the thorax will actually crush the vena cava, and then it'll stop the blood pressure and they will die. So you can actually kill someone using it inappropriately. Please don't do that because then they'll blame the tool instead of you. It's what the state of California will do. Signs and symptoms of increased work of breathing. You already know those things. Any questions? Just to review. Well, that's pediatric airway. Never mind. We're not on CPAP, but still the same. Any questions? As respiratory failures and kids develop, they just start slowing down. Their muscle tone gets softer. Their SpO2 drops, and they become altered, and then they become bradycardic, and they stop breathing. So you got to be watching for the signs of respiratory failure and ventilate them ahead of time. Any questions? Those are the different types of things that can cause pediatric respiratory failure that you need to be aware of when you're dealing with someone with trauma, neuro issues, dehydration, metabolic issues. Yes,
So let's say you got back from respiratory failure, that could put CPAP on.
not on a pediatric, no, not if they're under 8.
Oh, well, yeah.
But they're not
under
over
8.
But if they're over 8, generally, if you get them back, you don't need CPAP. CPAP's usually, like again, from like severe asthma, congestive heart failure, or severe pneumonia. But usually pneumonia, you don't do it because their blood pressure drops because they're septic. I've never seen an indication that that's happened. But it's a good question.
Did you just say we can't use CPAP on people with asthma?
No, you can.
You can, okay.
I said with pneumonia, you got to be really careful because they become septic and then hypotensive. And if you put it on them when they're hypotensive, it kills them. So you're better off just use a BVM if they have pneumonia. So again, we're off of CPAP. This is just pediatric airway management. Again, kids can do really well, and then when they just run out of compensatory mechanisms, they just fail. Go right into respiratory failure. Any questions? So you got to be aggressive and you got to be ahead of it. All right, I think we got time to go over pharmaceuticals. We can stay a little bit ahead. A little bit ahead. All right, let's learn about pharmaceuticals. Not for the day. Evaluate every action prior to making it. Those include your words. Benefit your patient, or your words going to, or your actions. Benefit your patient or benefit your patient assessment. Are they going to help improve the team and cooperating agency you work with? Are they going to make the chances for your patient to improve sooner with preventative care? If they're not, you may want to not consider doing them. The other thing you should always be considering, what is it that you expect to achieve from the action you're choosing or the words you're choosing? And if you do not get that result, what is your plan C, B, C, and D? What are you going to do next, and then do next, and do next? You need to always be thinking ahead and always anticipating what's going to happen if things don't work out the way you expect. Because I promise you, the majority of things in life that you do will not work out the way you expect. Any questions? All right, we're going to learn about general pharmacology, what it's about, how drugs work, what kind of drugs are, the dangers of them. So the definitions, pharmacology is the science of drugs, how they are prepared and how they work against your body. A dose is how much of a drug that you're giving. An action is what you're expecting the drug to do. Any questions so far? Y'all good? An indication is when the patient exhibits signs and symptoms or a general impression that you have developed that the drug may be able to help with. A contraindication is when a drug would make things worse for that indication. Side effects don't truly exist. All a side effect is an action that is other than the desired indication. Sounded kind of weird. Do I explain it to you? All right. This is my favorite analogy. So there's a drug called diphenhydramine. Its brand name sold is Benadryl. All right. So Benadryl is sold as an antihistamine for hay fever. So the indication for Benadryl is runny eyes, watery eyes, stuffy nose, sinus congestion. And the action that it takes is it dries up the sinuses and it stops the watery eyes by blocking histamines with fluid. causes that immune reaction. That's how it works. Make sense? All right. There's another drug called Nitol. They don't sell as much anymore. Better example that you guys would probably know better would be Tylenol PM. Tylenol PM indication is to stop pain and to help people go to sleep. For insomnia. Same with Nitol. Nitol is sold to as a sleep aid to go to sleep. The active ingredient for sleep in Tylenol PM and Nitol is the same one. It's a drug called diphenhydramine. It's Benadryl. It's the same drug, but it's for a completely different indication. Now, if you take Benadryl, they'll tell you the side effects are drowsiness and constipation. Okay? Because they're selling it to you for the indication of hay fever. Now, if they're selling it to you as Nitol, the indication is go to sleep. They don't tell you the side effects, drowsiness. It's the same drug, but now drowsiness is the side effect because it's the indication. The side effects are it dries up your sinuses and gives you constipation. Now, if you have problems with nausea and seasickness or motion sickness, you can go to the pharmacy and you can buy a drug called, Brian's drawing a blank on the drug. Huh? It's called, I'm way too tired today. My brain's just misfiring. Huh? Oh, no, that's Zofran. That's the modern. Dramamine. The Dramamine is indicated for motion sickness. Its side effects are drowsiness, dries up your sinuses. You want to know what the active ingredient in Dramamine is? It's called diphenhydramine. The exact same drug, made in the exact same factories, with 3 completely different names, packaged completely differently, but it's the exact same medication. Marketing. So the side effects are just the actions that are other than the therapeutic indication you're taking. Does that make sense? All right, so a trade name. So in our system, the way our pharmaceutical laws and system works, this is a multi-billion-dollar industry. Lots of research and development goes into it. Big, complicated thing. So when somebody, an agency, a pharmaceutical developer, develops a product, a drug, it has to go through what's called FDA approval through Food and Drug Administration. You have to go through trials. You have to prove it's safe, and they'll give it approval, but it can only be a prescription. And they allow the manufacturer to have a patent on that they're the only ones to sell it, and then they also are allowed to give it a brand name. Better. And that lasts, I believe, 7 or 14 years. And then they can reapply to have it done again for another part of the same time period. Nobody else can sell it, only they can sell it. That's how they reap back the amount of money that they invested in research and development to develop it. But anyway, after the time period when that expires, then anyone can sell it. But they can't use the brand name. They have to use the generic name that the developer also produces. They get to name that too, but then anyone can sell that. So I'll give you some examples. So probably the most common one is Tylenol. Tylenol is probably the best sold drug in the history of the world. So when the Tylenol patent expired, anyone's allowed to make it, and they call that acetaminophen. Acetaminophen is Tylenol, it's just the generic name. So anyone can make it and sell it. So you've got Walmart acetaminophen, Costco acetaminophen, Rite Aid acetaminophen, and it usually costs about 1/3 of what Tylenol costs. And in most cases, it's made in the exact same factory. make it, they sell it to, they just give it, they'll even package it for them in that factory and then ship it to Costco warehouse. And they sell it for a third of the price, exact same drug, made the exact same thing. Any questions? That's there's a trade name and a generic name. Then a prescription drug, after they studied it for being prescribed by a doctor, so prescriptions is a double safe system, and there may be test questions on that. The way prescriptions work is the physician has to write the prescription, then our pharmacist has to fill it. So the physician has to evaluate you as a patient, make sure that the indications are right, the side effects are right, or not side effects, contraindications don't exist, and that it's not medically going to kill you. And then when a pharmacist has to fill it, the pharmacist double checks the doctor, make sure that they also don't screw up, and that it doesn't conflict with any other medications that you're taking, and that it's the correct dose. And if it's not, then the pharmacist calls the doctor and they work it out. So it's a double fail-safe system for you as a patient. So after a period of time, usually 10 to 20 years of something being a prescription drug, if it's overwhelmingly proven safe, then the FDA will approve it to be over the counter, which means you can buy it without a prescription. So for instance, Advil, which is ibuprofen, was a prescription drug for like 30 years. And about 25 years ago, they finally approved it to go over the counter. But they also cut the dose. So generally the over the counter dose of ibuprofen is 200, whereas the prescription dose is 400. So it always cracks me up when people call 911 and I go, what do you call it? I need my prescription refill. Well, first of all, it's not what you call 911 for. I say, what's your prescription? Ibuprofen. It's like, well, you can buy that at the store. I can't because I have 800 milligram ibuprofen on my prescription. I said, okay, buy the over counter. 4 times 200 is $800. Any questions?
What is naproxen?
Aleve. It's a higher dose NSAID, non-steroidal anti-inflammatory drug. It's a more potent dose of ibuprofen. And that was actually, the brand name is Aleve. And the same thing, it was prescription forever. They finally released it. And there's a lot that goes along with this. Another one is oh my God, an anti-acid drug. They sell the hell out of Prilosec. You buy Prilosec over the counter now? Yeah, you go. So Prilosec went generic. They lost the patent on it. The drug company took one molecule out of it, turned it around backwards, and plugged it in. So it didn't change anything on the drug. Reapplied for a new patent. Man, I am getting old. I can't remember the name of it. What's that? No.
I'm trying to think what it's called.
Anyway, so then they got that drug for doctors to prescribe. It was no different than Prilosec, but then became over the counter. But they were able to sell it as a prescription drug for 10 times. What's that? No omeprazole, Prilosec? Yeah, no, this is a new drug
Oh, a new one.
that the same company came up with after Prilosec.
Oh.
So they could keep selling prescription, the same drug as a prescription at prescription prices. Nexium.
Oh,
So Nexium is Prilosec with one molecule taken out, put it in backwards, and put back in. It's the exact same drug. Any questions? All right, so you need to know routes of administration. How do you get medications into a body? So intravenous is the fastest way. That's direct, injecting it directly into the bloodstream. Then oral, which is the most common, but then it has to be broken out. That's just swallowing a pill. Then it has to be broken down by the digestive system and then absorbed through the intestine for the drug to work to get into the bloodstream. Sublingual is the second fastest. That's underneath the tongue. Any questions so far? Intermuscular is injected into the muscle with a needle. then it's absorbed to the tissues into the bloodstream. Interosseous is for paramedics and doctors that are too incompetent to start IVs. They drill into the bone marrow, then inject the drug into the bone marrow just as fast as IV. It's a lot more painful for the patient. Subcutaneous is not given much anymore because I found out people that are in shock, there's no blood going to the skin. So subcutaneous actually has a slower absorption rate than intramuscular in a patient in shock. The subcutaneous is right into the subcutaneous tissue, right below the skin. That's why it's called subcutaneous, below the skin. Any questions? Transcutaneous is when you put it on the skin, absorb it through a gel or a patch. Inhalation is inhaled. What's the number one inhaled medication in the world? Nope. Not even close.
Oxygen.
Ah!
I didn't think about that.
And then per rectum, which is the same as sublingual, but it's in the butt. So it's absorbed through the membranes of the rectum. Has the same absorption rate of sublingual. Here's a great example of inhalation.
So after weeks of painstakingly searching this rugged area the size of finally some kind
Correct. Any questions? All right. All right, so the types of oral medication. So tablets. So you take the active ingredient, which is usually less than 1% of it, and you mix it with 99% calcium and then compress it. Back in the olden days, the pharmacists used to do that right there at the pharmacy and then put it in a bottle and hand it over the counter. Now it's all done in factories. Capsules is when they use a liquid or a gelatin and they put it inside a gelatin shell and supposedly gives faster absorption. It's liquid, so the stomach is long to break it down, send it into the small intestine. Any questions? Solutions when you mix it with liquid. Most popular solution medication is alcohol. And then suspensions is when you put it like into a syrup, usually used for infants or small children medications. Children, infant Tylenol stuff comes in a dropper, the real sugary suspension. Any questions? Meter dose inhaler is one of the most misused medication devices on the planet. People have their meter dose inhaler. It's not working. The reason why it's not working is you need a space about that much before it hits the mouth for it to work. It has to have a spacer. For some reason, I don't know why, but 90% of the physicians and pharmacists do not tell patients that. The patients take their inhalers, they put it right up to their mouth, they go, and it sprays it directly into the back of their oropharynx. They don't inhale any of the medication.
I use my hand.
Good news is though, it's the EMTs. Any house that you're in, house, commercial building, gymnasium, school, any building, generally has a spacer inside. Just most people don't. Yes. Hold the toilet paper roll. You get toilet paper roll, put it in their mouth, put the meter dose inhaler on the other side of it, hit it, tell them to breathe, they inhale, it projects it, it gets the right volume at the right distance, and they get 100% of the medicine instead of 5% of the medicine, putting it directly in their mouth. It's not working. Any questions? Good tip for you guys. Then we have topical medications or lotions and creams and ointments. Transcutaneous patches, gels, and of course gases for inhalation such as oxygen, nicotine, Mary Jane. Any questions? All right. Depending on what state you work in, you may have many different medications. In California, you can currently use epinephrine and Narcan and oxygen and oral glucose. Any questions about oxygen? We've pretty much beat that puppy to death. Get close to breakdown. Activated charcoal will not be in your scope of practice. I can't even give activated charcoal anymore without a base hospital physician order. They thought it was a good idea. What it is it's burnt toast with milk and magnesia. It was given for overdose, people that overdosed on pills. The thought was, well, they've proven it does work. It binds to the medication in the intestine so it doesn't get absorbed into the bloodstream. Then you poop it out. The problem is when people would take overdoses, by the time EMS got there, gave them the charcoal, they became too altered, then they vomit. It's a solution. Then you'd have this sticky black charcoal, which would then get inhaled into the airway, cause aspiration, pneumonia, kill the patient. The idea is not to kill your patient. So activated charcoal, you can actually still buy this over the counter. Anyone can give it. But they're trying to get it not used nearly as much. Oral glucose is pretty much all 50 states. EMTs can give oral glucose. That's if someone has signs and symptoms, ultra level of consciousness, tachycardia, sweating, cold to the touch, and a field blood sugar that's low. An ACU check. We're going to teach you guys how to use glucometers, usually under 60. However, you can only give oral glucose if the patient is still alert but confused, and they have to be maintained in their own airway. You never give it to a severely altered person or a person that is unresponsive. It can include their airway, they can aspirate it, and it's not enough glucose to wake them up, so all it does is put them into a primal state, then they become combative, and you've just unsecured your seat. So for God's sakes, please do not do that. Any questions? Conscious patient, gag reflex that is altered. Any questions? Aspirin. You guys also have aspirin in your school practice. Aspirin, if they were to come up with this today, they'd be able to make billions and it would never be over. Aspirin has got unbelievable effects. First of all, it's a fantastic antiplatelet, which is why it's in your scope of practice. But generally, the way a heart attack works is you have little tiny pieces of plaque break off from somewhere else in the body or in your heart. And those plaques go down your coronary arteries. They block the coronary arteries, the distal parts, which then blocks blood flow, and then the heart dies. That's what a heart attack is. So it's not usually one piece of plaque or two pieces of plaque, it's multiple pieces of plaque. That's how heart attacks grow and get worse. So if someone takes aspirin at the first signs of a heart attack, what aspirin does is it doesn't dissolve the clot that's already blocking the artery, but it dissolves clots in wrapped. So it's kind of like the Iron Dome in Israel. So firing those missiles, it goes up and it knocks them out and explodes them, so they actually never hit the gas. Does that make sense? That's kind of like that's what aspirin does. Now, it's generally sold as a pain reliever because it is a pain reducer. It's also an anti-inflammatory. It's also an anti-fever. It's a fantastic drug. It's one of the best drugs ever found. And it's real simple. It's made out of willow bark. The pioneers used it. Any questions? But for you guys, we'll have it in your scope practice strictly for chest pain and for cardiac. And it can literally stop a heart attack in its tracks. So you will give it as soon as possible when that is your primary impression or your general impression. Any questions? That's what a meter looks like, or not a meter does. A spacer looks like for a meter dose inhaler. Any questions? All right, epinephrine. So epinephrine is your body's adrenaline, but this is an outside dose of it. that creates your fight or flight. What is your fight or flight? Sympathomimetic reaction. What it is it dilates your airways, dilates your pupils, increases your blood pressure, increases your heart rate, gives you everything your body needs to fight for your life or run for your life. Yeah? So, if you're having an asthma attack or a severe allergic reaction, that dilates your blood vessels and shuts down your bronchioles. So epinephrine does the exact opposite. So by giving epinephrine, it's the perfect reversal agent of asthma and anaphylaxis. Any questions? All right. So to administer epinephrine, you get to inject people with a needle. Anyway, you stick it into the muscle, you pull back a little bit to make sure you're not in the vein because you want to give it into the muscle, not the blood vein. Too high of a dose what you're given, you give intravenous. You want to give it intramuscular. So if you pull back, you get blood, you got to pull out. Get it out. Don't put it in the same spot. But anyway, pull back. If you don't get blood, it means you're in the muscle, then you just inject it into the muscle. Take your vital signs before and after. Any questions about administering epinephrine? Any questions about meter dose inhalers and spacers? All right, we're going to go a couple minutes, then we're going to send you guys to break. Nitroglycerin. Nitroglycerin is a smooth muscle relaxer. Take it in its liquid form and mix it with sawdust and pack it up tight in paper. You have dynamite. It's not a joke. It's the same thing. This is just a fraction of the dose of dynamite. But it's a smooth muscle relaxer. So what it does is your arteries are muscles. So when someone's having a heart attack or they're having decreased blood flow to their heart, and you give them nitroglycerin, smooth muscle relaxer, relaxes the arteries, makes them dilate, then you get more oxygenated blood flow into the heart. So in most states, you can't carry nitroglycerin on the ambulance or as an EMT. That's a paramedic level drug, but if a patient has a prescription for it, a bottle of it, you can make base hospital contact. You can get a base hospital porter to assist the patient taking their own nitro if they're having any questions. Now, you don't ever give it to someone if their blood pressure is under 100 systolic, because it will drop their blood pressure by dilating the artery. It doesn't just dilate the arteries in the heart, it dilates every artery in the body. So it drops their blood pressure rapidly. So if it's already below 100, we don't give it because it can kill them. We also don't give it to anyone that's sitting on a bar stool or standing up. You want them sitting somewhere they can't fall, because in case it does drop their blood pressure too much, the blood goes to the brain, they sink a few. We want to make sure they're not in a spot they can be injured from passing out. Give them the nitroglycerin. Any questions? All right. Narcan, that's not a drug. You guys can get lots of drugs. All right, go to break. We'll pick up Narcan on Monday.